everyone. Welcome to the Asia Ventilation or AVF podcast. And this is the ICU Tips and Tricks series. My name is Jason Phua, and today we are really happy to have Prof. Claude Guerin, who's going to talk about how Prof uses prone positioning in ARDS. So Prof is a professor of critical care medicine in the University of Lyon in France. He was the lead author of the very well-known PROSEVA trial on prone positioning in ARDS. And he's a leading figure in critical care as well as the management of ARDS. So Prof, thank you for joining us.
Thank you for the invitation. Very happy and honored to be here.
Thank you, thank you. Prof, I think we all know that prone positioning has been here for decades. It rose to even greater prominence after the PROSEVA trial that you led. And then of late, we've been talking about prone positioning in COVID as well. Maybe can we just start with the basics, the pathophysiology of how prone positioning improves oxygenation, that's one, and number two, reduces lung injury?
Okay, thank you. It's indeed a very important question. Improvement of oxygenation with prone results from reduction in intrapulmonary shunt, and the basic scenario is that we have more ventilation directed towards lung regions that still receives the most perfusion. And the basic scenario is when you flip the patient to prone, you increase the lung ventilation in the dorsal lung region, so you promote a functional recruitment of the lung. And it's very important to have in mind that those dorsal lung regions, even so they are non-dependent on the gravity, still continue to receive blood perfusion. So the perfusion, even in prone, is still redirected towards the dorsal lung region. So this is a scenario in which the ventilation to perfusion ratio are optimized, in particular in the dorsal lung regions, but probably there is also a homogeneous distribution of VAQ across all over the lung, but really the target is the dorsal lung regions. So that is the basic mechanism by which, prone position improve oxygenation. The second important pathophysiological impact of proning is the prevention or reduction of ventilator-induced lung injury, and we have mostly experimental studies that showed that what counts probably is the homogenization again of the distribution of the stress or strain across the lung. There is an overall global reduction of stress and strain. You can see that if you measure the transpulmonary driving pressure, for instance, it is reduced by proning, but also at the regional level, the distribution of strain, which is due to ARDS, and also due to mechanical ventilation, which is superimposed to ARDS, this stress and the corresponding strain are made more homogeneously distributed. That has been shown in many studies, most of them experimental by using lung imaging techniques.
Right, thank you. I also wanted to ask, given that it improves oxygenation and reduces lung injury, when should clinicians consider prone positioning for patients who are already intubated for ARDS? And I'm going to quote 4 different documents of thresholds of PaO2 to FiO2 or PF ratio. So, for example, your study, the PROSEVA trial, which was published in the New England Journal of Medicine in 2013, you showed that 90-day mortality was reduced from 41 to 23.6%, and you used a PF ratio of less than 150. Secondly, there is a widely quoted meta-analysis by Lavina Munshi and colleagues, Annals of American Thoracic Society 2017, where they found that the trials that was associated with mortality were in moderate to severe ARDS, i.e. PF ratio less than 200, which is higher than 150. Meanwhile, the guidelines by ATS, ESICM, and SICM published in 2017 suggested that we use prone positioning for severe ARDS, which is 100. So straight away, we have 100, 150, and 200. And I know that your own French Society of Intensive Care Medicine followed the PROSEVA trial, which is 150. So, and any thoughts what thresholds clinicians should use?
Yes, it's a very, very good question. And indeed, both thresholds are somehow evidence-based, as you nicely mentioned. You know, the 100 threshold has been, evidenced by the meta-analysis. It was the individual meta-analysis performed by Luciano Gattinoni using, the 4 largest trial before the PROSEVA trial, which is now a little bit old, I would say. And our trial, the 150 is, evidence-based from one trial. So you see, the problem is that with our trial, we tested really an hypothesis. We tested whether using prone position, setting out prone position in the setting of ARMA trial will perform better than the ARMA trial in supine, but we selected that in patients with, moderate to severe. But at that time, the Berlin definition was not there, and we defined severe to moderate at the threshold of 150, with a PEEP of at least 5 and an FiO2 of at least 0.6, which means a shunt, an intrapulmonary shunt, you can compute retrospectively around, 40-45%. So, there are 2 thresholds, and you nicely, summarize the evidence. I do agree with what you said, but it should be recognized that in the COVID-19, prone position was used even with threshold better than I would say 150. You have a lot of observational studies. Maybe we will be talking about that later. In COVID-19, that showed that the pruning was used even in patients with 250 or 300 milliliters of mercury. So that's it. Because probably it's the ambiguity or the difficulty of using just PF ratio. Probably, it is very important to have this threshold when we indicate some intervention at the bedside, but we know that it is not, the reflection of what happens really into the lung. But we have at that time a better way, to start any ventilatory intervention. I have also to add something about, a new trial which is ongoing in France in ARDS patients on prone. We are testing, a threshold between 150 and 300. So we like to fill the gap between 150 and 300. This trial is ongoing. We'll have the results. We planned 700 patients, and we'll have the results in the coming years.
Wow. Okay. So meanwhile, for the practicing intensivists, what would you recommend, that we start at 150 or higher or lower?
I believe in your data of the PROSEVA trials, so I recommend 150, and that is what I do. There is something else I would like to add, which is probably there is a desynchronization between VLI prevention and oxygenation. Probably, we do less bad, or we do better, in prone and in supine, regardless of oxygenation. If you have no oxygenation, but I think maybe we will discuss that later on. Even so, you don't improve really very much the oxygenation during prone. Probably you prevent ventilator-induced lung injury, because you contribute with the prone to homogenize the distribution of the ventilation and perfusion and stress and strain.
I see. So even if we turn a patient prone and we do not see a remarkable increase in the oxygen, it's fine because you are still likely reducing lung injury. And so you keep the patient prone.
Yes,
You don't turn up.
Yeah.
Okay. Are there any real contraindications to proning?
With the COVID-19, we have been using more and more frequently this intervention, and I would say that probably the unique, absolute contraindication is probably unstable fracture or dislocation of an important bone in pelvic, in spine, and even pelvic dislocation. Probably they are the only remaining absolute contraindication.
Right.
There is also the issue of the intracranial pressure in patients with acute brain injury. Probably a prone position in this situation is going to increase ICP. It depends how well it preserves the brain autoregulation, actually.
I often hear, in addition to what you have just mentioned, people saying that, number one, a patient is a surgical patient, so just had intra-abdominal surgery, and so we shouldn't prone. And that's one. And the other thing I often hear is, the norepinephrine dose is extremely high, and so he's not stable enough for proning. Can I hear your thoughts on this?
Yeah. It's so your question has two elements regarding the abdominal problem. It's not really a contraindication. There are observational studies showing that it is feasible. If you want to what you can do in case of surgical abdominal problem, you have to discuss with the surgeon. If the surgical team is going to agree with that. And the second point of your question is about hemodynamic support. Of course, prone position is not a new treatment of septic shock, and you have to have a patient stabilized on the hemodynamic point of view before proning. And for instance, in our trial, but in also the other trials, the patient had first to exhibit a mean arterial pressure of at least 65 millimeters of mercury, just as an example. But what has been shown repeatedly is that hemodynamic is stabilized, or even the cardiac output can improve with the prone sessions.
Right.
Okay. So it's not a contraindication. Right. It's not a contraindication, but you have a patient stabilized somehow.
Right. Okay. Can I also ask, because in recent years, there's been a movement towards light sedation or no sedation. And after the publication of the ROSE trial, we are moving away from routine neuromuscular blockade for severe ARDS. So what happens when we prone a patient? Do you sedate them heavily, and do you add on neuromuscular blockade or not?
So they are intubated. So we are talking about intubated patients.
Intubated,
yeah. So they are deeply sedated. In our trial, we used in almost, because of the accuracy trials performed in France, so we used an MBA. I will say that there is a strong trend to avoid an MBA, and we'll probably discuss about awake proning. So we have some, large experience of proning patients without any sedation and without any NMBA. It is probably, but we don't have really, the answer to this question, because there is no trial comparing, prone with sedation versus prone with sedation plus an MBA. And a trial is going to start very soon in France looking at this question, adding or not adding an MBA during prone position in intubated patient, because probably it could be that there is some, additional potential effect to prevent BLE if you use low tidal volume prone and an NPA.
Right. Okay. Speaking of low tidal volumes, do you change your ventilator settings based on whether they are supine or proning in terms of, say, tidal volume or driving pressure or PEEP, etc.?
So what we do, is we change FiO2 because in the vast majority of the patient, oxygenation improves, and the reflex is to reduce FiO2. And also you can also modulate the PEEP patients, if you really titrate, individually the different settings or not. In our trial, for instance, we use a PEEP and FiO2 table, the one of the LAMA trial, and we modulate the PEEP and FiO2 together in both positions. Again, there is no studies showing that you have to change in a way or in another way the PEEP or the FiO2. So I think my impression is that we drive the changing ventilator setting from the change in oxygenation, but probably we have to be more careful in looking at the driving pressure, probably, but in this case, probably we would need transpulmonary driving pressure because it might be that by changing the chest wall compliance, the prone position should be monitored by using the transpulmonary pressure.
Okay. Yeah, thanks. In your trial, the pruning went on for 16 hours, but the guidelines, the ATS ones and the ESICM ones, do state 12 hours. And I think that's based on meta-analysis.
Yes.
So you go for 16 or?
Yes,
or
17 on average.
17.
17 patients receive 17 continuous
17.
hours.
Right. Okay. And one of the things we struggle with is that when we turn them at the 17th hour to a supine position, sometimes they desaturate, and they are still. We can still oxygenate them by increasing the FiO2 in the supine position, but it is very clear even in the first half an hour or 1 hour that the PF ratio has gone below 150 again. And I think many of us, we follow your PROSEVA protocol where we wait 4 hours, and if it's still less than 150, at 4 hours, we will turn them prone again. So I think the first question is, do you sometimes not even wait for 4 hours because it is already clear that they are desaturating, and so you just turn them prone again? That's one. The second question is, are there patients where you don't even bother turning them supine because at the 17th hour, their PF ratio is still extremely low, and you know that they will desaturate, or you will still try to turn them supine? And the third question is that there will be patients that we just prone supine, and it goes on for a few days, sometimes for a few weeks, and there's no end to it. Is there a point where you say enough is enough and you are not going to prone them anymore? Yeah, thanks.
Yes, thank you for this question. That are very important practical and also theoretical, issues. Actually, after the 17 hours, the patient is put supine. If there is a rapid desaturation, we put the patient immediately back to prone. We don't wait the 4 hours assessment for sure. And in the trial, when the patient was stable and was able to wait for 4 hours, and when this threshold was not there, we put the patient back to prone. But we did that during the 28 days of the protocol duration. So some patients, but there were a few, some patients received 28 prone position sessions. Just by the protocol, but that was only over the 470 patients included. Only less than 10 patients exhibit this pattern. Most of them, on average, they receive 4 sessions. But you are completely right. In some patients, so I would also add something that maybe the changing position may also have an effect. If you move from supine to prone and vice versa, you change the monotony of the mechanical ventilation by this way. But it is absolutely true that, and that was the case in COVID-19, that patients receive prone position for a long time, for many weeks, and at some point we say, well, is it right what we are doing? And in some patients, after 3 or 4 weeks, we said let's try to change the strategy and to stop sedation and start spontaneously breathing and see what happens. And it was not protocolized. That was not studied in details, but this is something you can you can test in the ICU under a close monitoring.
Right. How about in the first few days, and the PF ratio even on supine is say 90. Sorry, even on prone is say 90 at the 17th hour. Do you even turn them supine, or you just keep them prone?
We keep them prone. We keep them prone. Even so, we have in mind the ECMO indication. So we have to have that in mind. And if there is no deterioration of oxygenation, we continue prone. If there is no deterioration of oxygenation, CO2 or pH, we continue.
So you don't. Do you mean that even though you have a 17-hour prone duration, if the patient's PF ratio is routinely less than 150, you will not turn them supine, or am I understanding it correctly?
I'm not sure I understand. What do you mean? So your patient has received...
So your patient has received 17 hours of prone, and you have not turned them supine yet. At the 17th hour, say your PF ratio on prone is still quite low. It's say 90. Would you bother?
You try to
you would increase.
Oh,
do you?
No, we don't.
Oh, so you will still turn them prone?
Yes, we test the supine.
Right. So you will turn them prone just to relieve the pressure on the face and for 4 hours, and then you turn them supine again. I got it. Yeah, right. Got it. Right. Thanks. And we were talking about awake prone positioning, especially for COVID.
Awake.
Yeah, awake prone positioning, pre-intubation, and I'm quoting from the meta trial of the 6 randomized controlled trials that was published in the Lancet Respiratory Medicine last year, where they looked at patients who have a PF ratio of less than 300, so a much lower threshold on high flow nasal oxygen, and I think the hazard ratio for intubation was 0.75, although there was a trend for reduction in mortality, but it wasn't statistically significant. My question is, has this trial changed your practice? Has it made you more prone to awake proning? Has it changed your thresholds of post-intubation proning? How has it?
Not really at that time, because as you said, this trial was performed in COVID, and we have no non-COVID ARDS patients, and there is no reduction, in mortality after all. But it is a very positive result. We perform also a meta-analysis, over this meta trial, and the paper, the first author is J.I. Lee from Chicago, and the paper is accepted to Lancet Respiratory Medicine. So we just confirm, the data of the meta trial, but the meta trial has as a big weight, to the results of the meta-analysis, but it confirms. And what we have shown also is the results is there is a reduction in intubation, but not on mortality. And if you perform the awake prone in ICU, in non-ICU, there is no difference regarding intubation and mortality also. And also the intensity of the respiratory support, it is efficient when you have a sufficient intensity of respiratory support at the baseline. And there is a still unpublished trial that showed that in a patient receiving low oxygen support, the prone position get worse in terms of oxygenation and mortality. But the study is not still published. So we didn't really change our practice at that time. And maybe there is another, issue regarding the awake prone position, which is the use of non-invasive ventilation or CPAP instead of high flow oxygen as respiratory support in prone. And we have, it is the issue of the work of breathing and inspiratory effort and the risk of, patient self-inflicted lung injury. Can, prone position reduce this risk or not? And in the literature, we have two studies at that time, I think. One showing that under CPAP, the work of breathing is reduced in prone, but one in non-invasive ventilation, the thickness of the diaphragm measured by the echo is worse than in prone than in supine. So it is, I think it's with the awake prone position, we enter into a new field of, practice, but also research. And in particular, in terms of, self-inflicted induced lung injury and which is the best, respiratory support we have to use in those patients. I think it's a fascinating era. And there are trials that are planned, to be done in awake patients, non-COVID ARDS patients in the next future.
Right. So even today, what is your actual non-research clinical practice? Do you turn patients awake prone? And when do you do that?
Yes, we do, but not that much.
Not that much. Right.
Not that much.
Okay. So waiting for more studies and for the thresholds as well as the respiratory support. Yeah. Right.
Because because the study has been done in COVID, and now we have patients with classic ARDS, and we have no data about that.
Yes. Which reminds me about COVID. This whole debate about H-type and L-type patients, and the theory that in patients who are type L, where they don't really have a lot of lung edema, and a lot of the hypoxemia is due to VQ mismatch due to endothelial dysfunction. And as such, the theory that proning these patients will not make much of a difference because it's a blood flow issue, it's not a lung ventilation issue. What do you think of that theory? Does it apply to yes?
Yes, very good questions. It's a fascinating, concept developed by Luciano Gattinoni in 2020 during the first wave. Actually, we have no data, we have no new RCT comparing supine to prone in COVID. We have just been using the evidence we got before, and we have no data regarding the L or H phenotype and the effect of prone. We have several observational studies using prone in COVID with or without a control group of classic ARDS patients, and it looks like there is no effect, of the compliance in terms of response to prone. It looks like patients did respond in the same way as they did with the classic ARDS patients, but what you can, use as an argument against, the L phenotype is that I will assume that the L phenotype is going to be prevalent before intubation. If it is an early stage, because in the concept of cyanogen pneumonia, the H phenotype might result from ventilator-induced lung injury or organization of ARDS. At the early stage, the L phenotype should be prevalent, and then the prone position should not be effective at that time. But what we have been discussing that awake prone position is effective at least to prevent intubation. So I don't know. I really don't know.
Yes. Yeah, it makes sense. Yeah, it makes sense, because if L phenotype were early, they should not have responded to awake prone positioning, because that's early. Yes, I see your point. Yeah. Thanks, Prof. I just have one final question, and that's, you have already mentioned many of them, but what are the burning research questions that need to be answered for prone positioning?
So I have three fields. The first is what happens in intubated patients above 150. So a trial is ongoing, and probably we may fill the gap. Second, in non-intubated patients with non-COVID ARDS, and three, the use of prone in ECMO during ECMO. Right.
Thank you so much, Prof. I've learned a lot from you, and I'm sure the audience of the Asia Ventilation Forum podcast will learn so much. And I really appreciate that it's both a mix of research as well as what you actually do on the ground, which I think really matters to a lot of us. So thanks very much once again.
Thank you. Thank you, Professor.
Bye. To all our listeners, this has been the Asia Ventilation Forum ICU Tips and Tricks podcast. We are available on YouTube and Spotify, and so please feel free to share this, like it, follow it, subscribe, and just look forward to seeing you at the next podcast. Till the next time. Bye.